Yeah, thank you very much for a very kind and generous introduction. Good morning, everyone, to you. Good afternoon from Stockholm, where it's a nice and sunny day. I hope you can see the slides. Let me put it in presentation mode. Thank you very much for the invitation. It's an honor to come and speak to you on this platform. Some of your previous speakers are good friends, so I'm delighted to be in good company. What we want to talk about today is the innovative approaches to liver transplant and the new revolution in transplantation in the form of organ preservation and perfusion. These are my disclosures, and really what I want to focus today is on a number of things. First of all, to understand why we need organ perfusion technology, and if so, which are the ones that are currently in clinical use in liver transplantation. If we embark on using those, what are the clinical outcomes and how do they impact on the organ utilization? And of course, what are the benefits, the added benefits of machine perfusion in terms of organ assessment? Then I want to touch a little bit upon recipient and also donor selection, and how and when to use the technologies and where are we going into the future. So first of all, let's consider why we would need an organ perfusion program, and allow me to illustrate this with the figures looking at donation after circulatory death, DCD. And what you can see here in Europe, but also in the United States, is there a significant increase in the utilization of DCD donors. To the point that in some countries in Europe, such as Belgium, Netherlands, and the UK, these represent now 40 to 60% of the entire donor population. So really, DCD has now become the primary path to donation. Now, some of those images detail the issue with the DCD donation. As you can see on this particular slide here, apart from the iatrogenic injury, there's a slightly unequal perfusion of the liver, same here, and also same here for the kidney. So there is a question about whether these organs are going to be functioning after transplant. The outcome of this questions about organ utilization and organ appearance is that there is a lack of consensus whether they should be used or not, and physicians, quite rightly perhaps, are scared of using such of those organs. And this is illustrated here from some of the data from the UK, where you can see that increasingly, particularly for DCD, kidney, pancreas, and liver, a significant proportion of the donated organs are not used. This is less so in the DBD, but you can see that there is still a need for organ utilization improvement there. If we consider the scope to increase DCD utilization, this is a huge margin that will make a huge difference in terms of where we go with transplantation these days. Firstly, on the left-hand side, you could see that the temporal trends in organ discard remain constant and significantly higher in the DCD in black versus DBD. The second point to note on this particular slide is on the right-hand side, and this is US data. And you can see that OPOs have a different risk perception and risk acceptance rate for the organs that they retrieved. And there's a huge variation, some of the OPOs being well under par compared to the others. So there's scope to flatten that curve by improving organ utilization. And finally, for the DCD liver transplantation, one of the challenges with DCD in particular is the threat of ischemic cholangiopathy, illustrated here, where you can see that the white ducts are not joining together here. Clearly, there is an ischemic injury, and this leads to higher morbidity, mortality, hospital cost stay, and significant rate of retransplantation. So therefore, it's an argument that we need perfusion technology. And if we were to summarize the journey between the donor and the recipient hospital, there are a number of stages where machine perfusion technology can be used. That can happen at the retrieval, during preservation, either pre-ischemic, intermediate, or pre-implantation, and certainly before transplant at the recipient hospital. There's also a number of temperature that we can consider, either staying hypothermic or increasing the temperature towards full normothermia. But as we increase the temperature, although we may derive more benefits, we also see an increase in complexity in terms of managing these devices. So there's a quid pro quo there, but there's also a balance to strike between benefits and risks. So let's focus on liver transplantation because this is why we are here today. We can start at sub-zero and increase autonormothermia. You can see here a number of devices, a number of approaches, either hypothermic, subnormothermic, and normothermic. But if we were really to speak about those that have made an inroad into clinical utilization, really we're talking about hypothermic and normothermic devices, either regional perfusion exclusively in the DCD donor, applied in the donor, or ex situ normothermic machine perfusion applied at various stages in the journey that I've showed you earlier on. Why are we looking at technologies? And machine perfusion technology is not new. It was tried earlier on by Belzer and others, but the technology was not up to speed. Now we see an explosion of devices because technology has really improved so much that allows us to devise a number of machines. They have a number of potentials to use. First of all, increasing or extending preservation time. And this allows particular logistic factors and patient factors such as difficult hepatectomy to be tackled. They also offer an improvement in assessing viability, and this may well lead to an increased utilization both in DBD and DCD because we have a better understanding how those organs will function. And of course, with all that, we are expecting improved outcome, both in terms of early allograft function, but more importantly, long-term function with fewer organs being lost, or indeed bile duct viability improvement in this situation for the liver. But there is a challenge here because we have a wide choice of technologies. And the question is, how do we choose from all the devices that you see on the screen and the new devices that are coming to practice virtually every year? I think there's a number of points we need to consider. First of all, what is it we want to achieve? Is it extended preservation? Is it a functional assessment? Is it the ability to repair the organ that has been damaged during the donation process? Then we obviously need to consider the available clinical evidence, and we'll come back to that. And of course, the logistics and the availability of each technology, which has to be supported by relevant funding and expertise. And of course, different organs have different needs. And I don't necessarily mean kidney, liver, and pancreas, but also between different livers that are donated, we will have different needs in terms of improving the quality of a particular given organ. So where are we currently in terms of utilization of some of these devices in situ and ex situ? And here we see normothermic regional perfusion as it's applied in the donor. We've got NMP, hypothermic machine perfusion, or controlled reworming from HOPE to NMP and then transplant. But just to illustrate to you the complexity of the challenges we have now, here are some of the competitions and the combinations that are currently exploring. Now, some of these are in practice, but the question then is, how do we compare such a multitude of choices? And this is where the biggest challenge is currently in clinical practice. So let me start about considering, first of all, the DCD transplantation. And I would start here simply because, as I've shown you already, it's exploding in Europe, but also there's a significant increase in DCD donation in the United States. The challenge with the DCD donation is that we have a period of warm ischemia followed immediately by a period of cold ischemia with organ procurement. And the combination of those two is very detrimental to the function of the livers. So the first intervention that we can undertake here in the donor is actually to separate those two by a period of normothermic regional perfusion, which essentially means connecting the entire, connecting the donor to an extracorporeal circuit made of an oxygenator and a pump, and returning donor's reoxygenated blood to the abdominal compartment. Now, if we limit ourselves to abdominal compartment, we are talking about ANRP, abdominal normothermic regional perfusion. And in recent years, this has been extended to include the lungs and the heart in the format of thoracoabdominal normothermic regional perfusion, TANRP. Normothermic regional perfusion has started many years ago in Europe. We've been doing it this particular approach for about 12, 13 years in the UK, and now in my new place of work in Stockholm. And it's gaining pace in Europe, but it's also now gaining pace in the US, driven primarily by the utilization of the heart. Now, what we do know is that despite the widespread or increasing spread of normothermic regional perfusion, there are significant technical variations, and it doesn't appear to be a cohesive or consistent approach. Some of the challenges and the differences are with regards to cannulation. Some countries have a permissive legislation that allows pre-mortem cannulation or wiring, which limits then the shortens, I would say, the functional worm ischemic time. In many countries, including in my own practice, we undertake laparotomy and cannulation, similar as we would do a standard procurement. There's also the ability to deliver pre-mortem heparin, and this is driven again by legislation. It's not possible in many of the countries. And I think the biggest difference is relating to the retrieval of thoracic organs, either cold in situ, both for heart and lung, or including into the TA-NRP. And then, of course, some technical variations in the form of whether a heat exchanger is used to maintain the temperature constantly at 35, 37 degrees, or indeed if you use a reservoir or a closed circuit. Now, there are also some important practice variations relating to logistics and also to donor and recipient factors. So first of all, donor age. As you can see, certainly in many countries that has increased steadily in keeping with the increasing in the donation and population age. But in some countries, more recently also in the UK, but certainly Spain and Sweden, we do not have a limit, and we go and use every single donor that we can attend. Next is variation in the agonal phase, and this is a duration of waiting before the donor passes, and you can see there's shorter in the US with increasing times in many European countries. The biggest difference probably relates to the functional worm ischemic time, which is not uniformly defined. Certainly in Europe is defined as a blood systolic of under 50 or 60 until cardiac arrest or reperfusion in the donor, I should say. And you can see this is widely variable. And of note, it's longer in Italy purely because there is a requirement for no-touch period of about 20 minutes. Generally speaking, NRP is undertaken for about 2 hours, and this allows a significant modification of the organ quality such that in practices such as in Spain, such as in Sweden and the UK, these have been now considered as equal quality with DBD donors, and therefore the cold ischemic time has been extended accordingly. What about the outcomes? Because I think this is what matters. So it's important to note that NRP has been driven primarily by DCD liver transplantation outcomes, because as you can see in this initial series and the 3 highlighted multinational national series, you can see that ischemic cholangiopathy in the column highlighted in red is significantly lower compared to what it was without the use of NRP. Certainly in our experience in Europe, it's gone down from about 25, 30% to single digits. But these were the initial series looking at complications of DCD versus DCD NRP. Whilst more recent series have started to produce comparisons with DBD. And I think this is important to note here that NRP now, in those centers that have reported comparisons with DBD controls, has brought the incidence of ischemic damage to the biliary tree to similar levels. This is at the bottom there in red, you'll see the most recent US data reported by the San Diego group. This is a multi-center study. And you can see again, in over 100 cases, the use of NRP has led to 0 ischemic cholangiopathy, which is a significant change to the current clinical practice. But it's not just about ischemic cholangiopathy. A meta-analysis undertaken in Europe based on the publications up to about 22 shows a significant improvement both in allograft dysfunction, all type of biliary stricture, and anastomotic strictures. And as I said already, ischemic cholangiopathy. So there is something with NRP that changes that, and I think it's the separation of the warm and cold ischemic time that triggers its benefits. Although we are in a liver meeting, it's important to highlight that because NRP is applied in the donor, it's not just benefiting the liver. And I will simply illustrate this with one single slide from the kidney graft outcome recently published from the US. And there's two important things to note on this graphic abstract. First of all, is a substantial increase in the number of kidney transplants from DCD donors, which is a tenfold increase in 2 years. This is staggering, tenfold increase in 2 years. And secondly, this was associated with a significant reduction in organ discard and significant improvement in function with a reduction in delayed graft function, which of course benefits all hospitals and reduces the costs. So I think this is why NRP is probably becoming the first choice for the DCD donation. If we come back to the liver transplants, what we've noticed after the operation, after the transplant, is that the morbidity and mortality up to 1 year is significantly reduced with fewer readmissions, no cases of ischemic cholangiopathy, fewer interventions illustrated here at the bottom of the slide with reduction in MRCP, liver biopsies, and CT with contrast. And as a result of better management of the biliary tree and fewer complications, we have a consequent lower retransplantation rate. But this is good not just for the patient, not just for the transplant center, but also for the hospital at large. And you can see here some data from the UK, where the two centers undertaking NRP at that stage, Cambridge and Edinburgh, reported a substantial reduction in the ITU stay. So even if it's 1 day, that is a significant reduction in costs for each patient. Our anesthetists are also very happy because the reperfusion is significantly improved in NRP with a reduction in the reperfusion syndrome, as you can see on the slide, fewer doses of pressors, and actually more concentrated in the immediate perioperative phase at a low rate and shorter duration. So clearly benefits all over. So better organs, but more organs. I think that's the next important question. And here we have a report from the UK, which we published last year in Transplantation. You can see that the utilization of NRP organs, DCD organs where NRP was used, is much better versus DCD. Sorry, it's double. But also it's coming closer to the DBD, but I think that there's still a bit of a way to go there in terms of using more organs. Now, I mentioned at the beginning earlier in my talk that there's two strategies to recover the organs, either abdominal NRP or TNRP. And I think it's important to discuss a little bit about the TNRP because this seems to be the primary driver for the development of or the introduction of NRP in the United States. So TNRP has demonstrated substantial benefits in Papworth. That's the center in the UK that drove the implementation of this particular technology, where, again, just to remind you, it's perfusion of abdominal and thoracic cavity with the exclusion of the brain and the legs. Now, the Papworth center have devised a number of assessment criteria for the heart, and their argument is that in the TNRP scenario, heart is restarted and drives the circulation in situ, and therefore you can undertake a functional assessment as demonstrated by those slides, compared to the direct procurement where the heart is taken out very rapidly in cold, blood is removed for the ex situ machine perfusion, and abdominal NRP can be restarted, isolated afterwards. But clearly for the heart alone, a TNRP is better. Well, one of the questions is, well, how does it make, what is the impact on the abdominal organs and particularly the liver? And this is an important paper coming from Pedro Catarino in Los Angeles, formerly of Papworth in Cambridge. This is a multi-center study looking at the TNRP versus direct procurement of the heart. And as you can see here, immediately that there's a substantial improvement in utilization of the livers when TNRP is used versus direct procurement, with better function also for the kidney. And in Europe, TNRP is not very common, and therefore we are still undertaking a lot of lung retrieval in the cold. So lungs are retrieved cold, and the abdomen is undergoing abdominal NRP. And in this analysis coming from Spain, one of the questions was, what happens with the lungs and the livers when the two are retrieved simultaneously? And the important message from this paper, messages I would say, are three. The total worm ischemic time is quite short. Equally, the liver functional worm ischemic time is short, and there have been no documented technical problems. But the key point for this to be successful, in other words, cold retrieval in the chest, NRP retrieval in the abdomen, is that thoracic hemostasis is critical, so we don't lose blood, and we need to preload the circuit with blood prior to cardiothoracic explant. And finally, with about NRP has also facilitated pediatric donation, and this is growing slowly but steadily. And this is a preliminary report from Spain, where you can see that 6 pediatric donations have been facilitated, not necessarily to the lower age, but anyway, it's a reasonable progress. And most of them were with antemortem cannulation, which is permissive in Spain. So clearly we're beginning to see an expansion that NRP is used in all donors. Okay, so what happens if we don't have access to NRP? What about individual ex situ organ perfusion? So now we're moving in that journey, we're moving that the organs have been retrieved, and we can do either perfusion during transport or more commonly applied at the implanting center. And one of the things we've done quite well in Europe is to use hypothermic oxygenated perfusion. It's less common in the US, but I think there's a clinical trial going on at the moment to have FDA approval. This can be done in 2 ways, either perfusion through a portal vein alone, which is what was proposed by Dudkovsky in Zurich, or dual perfusion, portal vein and hepatic artery in Groningen. And is done prior to liver being transplanted. The advantage is, of course, maintaining cold, crystallite perfusate, and what all the groups have demonstrated is that actually oxygen is replenished, and in theory is sufficient to avoid ROS damage. The results have been pretty good, and in fact, there's one study that compared DCD untreated with HOPE with DBD, and again, it's beginning to show that perhaps in the DCD scenario, hypothermic oxygenated perfusion leads to fewer ischemic biliary complications. And this was indeed confirmed in a randomized controlled trial from the Dutch group that led by the Dutch group that published in the England Journal a few years ago, which showed that when HOPE is used, ischemic biliary complications, those that are clinically significant, appear to be significantly lower. But there's a catch with this paper. It's not just about those that are clinically significant. When you read the additional data, what you can see, in fact, that overall, the ischemic biliary complications are comparable. So the only difference that was seen is actually in those symptomatic ones. But overall, we have a similar number of complications, and it will be interesting to see how they develop with longer follow-up. Unfortunately, the DBD grafts do not appear to benefit that much from hypothermic oxygenated perfusion. Of course, there's lower PKLT, fewer complications maybe, but in fact, the ischemic complications for the biliary tree are staggeringly high. 22% in a DBD scenario is pretty much unacceptable these days. So if we were to sum up the benefit of hypothermic oxygenated for liver, they do reduce biliary complications, early allograft dysfunction, and quite interestingly, there is a suggestion that it may reduce acute rejection rates. This is something we've seen in the kidney, but I think we need more information to absolutely make that statement. And it reduces retransplantation rates. But some centers have thought, well, it's good, but it's not sufficient. So why not normothermic machine perfusion? And what you see here, there are 3 devices on the market. Transmedics and Organox here are mostly used in the US. This is the ex vivo device that it's more commonly used in Europe. Essentially, this allows the liver being perfused at full normothermia with oxygenated blood and some drugs and infusions. The benefit of NMP has been supported by this paper published now 5 years ago in Nature, which showed, first of all, a significant reduction in the discard rate. This is all livers, DCD and DBD. And this was achieved against a phenomenally long preservation time, almost 24 hours. And as you see on the left-hand side, the benefit appears to be primarily for DCD. Now, this study has been criticized because the endpoint was peak AST, which from a long-term point of view does not make much of a difference, but it's a pivotal study because it demonstrated that livers can be preserved outside the human body for 24 hours with good outcomes post-transplant. However, NMP has not demonstrated a substantial benefit for DCD for ischemic biliary stricture, and there are a few studies published, and you can see here that NMP has anything between 11 and 30% incidence of biliary complications. So if we sum up so far, the benefit of HOPE versus NMP versus NRP in terms of allograft dysfunction, primary non-function, ischemic cholangiopathy, and complications, you see that overall, each technology has some benefits. Those are odd ratio that are all significant, except the one that's highlighted here with regards to one-year graft survival. So what about organ utilization? Because I think that's also an important point for OPO and all the transplant centers. If we look first of all at NRP, this has changed significantly the number of organs that are procured from DCD donor with a doubling of organs recovered. And also for machine perfusion is an interesting picture. This is a study we did in multi-center study across Europe and US, and you can see a number of things. First of all, where machine perfusion is used routinely, there is a significantly higher utilization of DCD organs. In the UK, we notice a substantial benefit when NRP is used versus standard retrieval. And a similar thing was noted in the OCS trial in the US, where there has been an increase in utilization versus control. And as I said, for NRP, there's a significant improvement in liver utilization, pancreas utilization, but more also quite interestingly for kidneys. But there's an additional benefit of a normothermic machine perfusion over hypothermic machine perfusion. This is illustrated by the study undertaken by the Birmingham group, which took all organs that were turned down by every single center in the UK, perfused them normothermically, and if they met criteria, transplanted. And you can see on the Kaplan-Meier curve, very good results. We have seen a similar thing with NRP, where we went for kidney-only perfusion for the donor. So the liver was turned down for whatever reason on the grounds of history. And when we undertook the NRP and the biochemical assessment of the liver, we saw very clearly in purple that the lactate and the ALT was comparable with those organs where the liver was accepted prior to retrieval. So these livers were reoffered and transplanted successfully. So we rescued in this way 30% of the organs that everyone turned down. So clearly there's a lot of organs out there that we should use and we can potentially rescue with this machine perfusion technologies. A similar thing was seen in the Netherlands, where livers that were declined on history were salvaged with excellent survival and very good results in terms of ischemic cholangiopathy. And it's not just about the DCD, but also about the very good grafts. And here we have a recent report from Innsbruck, where the livers were split. The pediatric transplant went ahead, and the extended right graft was perfused on the machine for up to 17 hours, to then allow subsequent transplantation, avoiding nighttime or parallel transplants. So we have seen so far a significant improvement in organ utilization and better quality of the organ. So why do we think that is? And I think one of the key points is improved organ assessment. Now, we know that perfusion technologies allow that to happen. And you can see here that as we move from static cold storage through temperature and we increase to normothermic perfusion, we also have a number of added benefits. At normothermia, the liver becomes fully functional, and we can assess not just the cell type specific injury markers, but also the biliary production and quality. Just to give you an example, and this is for normothermic perfusion and NRP in particular as well, we have a number of dynamic assessments. So NRP is undertaken for 2 hours. You can see that we look at the biochemistry, but also we look at the blood gas analysis, and all those allow us to have a better and more sophisticated information about the liver. In fact, we have a wealth of information, of which some is used to modulate the perfusion oxygenated parameters, while some allow us to understand the level of hepatocyte function and the damage and the metabolic function, and obviously answer the key question whether the liver is going to work. Just to illustrate this a little bit further, this is one of the first NRPs we did. You can see that the perfusion appears like a DBD, and we have excellent flow in the portal vein and hepatic artery, providing us with the reassurance that those livers will work well. A number of criteria are used to evaluate the organ during NRP. These are the traditional ones, biochemical and macroscopic assessment, but with different ranges and different acceptance criteria depending on the jurisdictions you work in. I won't labor the point because this is an evolution. It changes, and I think we are still to demonstrate the validity of any of those criteria in a clinical trial. One of the criticisms for hypothermic perfusion was, well, we can rescue organs, but we don't know whether they work. A lot of activity, a lot of science has gone behind this, and now the Swiss group proposes to use a flavin mononucleotide, which is released from mitochondrial complex 1 and can be measured photometrically during perfusion. And they have demonstrated a good correlation between the perfusate FMN level and the function of the organs that are transplanted. But again, this has not been tested by other groups or confirmed by other groups or tested in a randomized trial. Ex situ NMP, similar to NRP, allows us a fully functional assessment. A number of criteria have been defined by the Birmingham, Cambridge, and Groningen group respectively. They all revolve around the lactate, the perfusate pH, and the ALT, and the glucose metabolism. And more recently, we're looking at the biliary parameters. But again, none of them validated in a randomized trial. So from all the factors that we've demonstrated so far, it appears that the lactate and the glucose and an ALT at 1 and 2 hours appear to be the ones that are related to the early allograft dysfunction quantified by the MEF score. But yet we have not got a good understanding of the long-term outcome. It's interesting that the interpretation of these parameters vary significantly between surgeons, and you can see here in a multi-center study by the Carlis from Milan that all these factors bear different significance and different interpretation by surgeons. So we still got a long way to go to understand a well-defined key parameter set. And perhaps we need to move to more sophisticated ways. And this is a recent report published in Science Reports, which is looking at the real-time monitoring of mitochondrial oxygenation. And the group has demonstrated that on machine perfusion, they're able to correlate using Raman spectroscopy, the mitochondrial oxygenation and the relations with transplantation. We used a similar method with a portable Raman spectroscopy, and we demonstrated that during NRP, there's a clogging of vasculature by red cells, which once NRP is undertaken, disappears, and the liver is almost comparable to the pre-donation stage. Cell-free mitochondrial microRNA, have been used and proposed. They appear to correlate well with the degree of pathological injury as quantified by Suzuki scoring. But again, these require further validation. One interesting approach is looking at the bile proteome, because the issue with the DCD liver transplant in particular is the biliary tree. And this is an interesting and very elegant study from the Groningen group, which looked at the bile proteome and beginning and at the end of perfusion. And they've seen a number of things. First of all, here you can see that at the start and after 150 minutes of perfusion, there's a clear differentiation between expression of the various genes. But then they correlated with a histology of bile duct injury where there was a low or a high level of injury. And you can see again, there's a clear separation in terms of viability. So this particular analysis will allow us to differentiate, once the organs are perfused on the machine, whether they will have a problem with the bile duct, and allow us to select the organs accordingly. And I think we need to move towards this sort of analysis, which is more metabolic, is not just ALT and AST, is actually determining with an NMR the metabolic analysis of the organs. And this is some work we've undertaken in NRP, where after 45 minutes of warm ischemic time or after 2 hours of NRP, we compare the graft. And you can see very clearly a nice separation here on the right side between the ischemic damage on the right upper corner quadrant versus the NRP on the lower bottom quadrant. So we're beginning to see that we're moving away from the traditional biochemical analysis to more sophisticated assessment. So now we know that we can assess the organs, we can get more organs for transplant, but how and when to use these technologies? Because how do we decide which one to use when? And I think it's very simple. I think all donors should undertake some form of machine perfusion technology, and any recipient is suitable for this graft, and in particular for DCD. Age is one of the issues which has been limiting for extended criteria donors, and in particular DCD. And you can see that 3 years ago, those were the age limits where we function. Now we moved from no age limit in many of the countries. And as you can see here on the right side, we pushed the boundaries up to 80-year-old with very good liver utilization, and again, no ischemic cholangiopathy in DCD. So really, there's a lot of scope to increase utilization. We have also seen a vanishing significance of functional warm ischemic time with NRP. Now we need to push this beyond 30 minutes, which was traditional, and the results are very good in terms of liver survival. As a result, the use of NRP, in particular in Europe, has changed from these traditional scores for donor and recipient, very conservative to allow good outcomes, to very liberal, essentially every donor and any recipient, no matter whether they're fulminant hepatic failure, retransplants, and with an extended cold ischemic time. Ex situ machine perfusion adds another benefit, which is transplant logistics. 80% of the current transplant activity happens overnight, and really this is not conducive to a very good work-life balance, and certainly longevity in clinical practice. But using machine perfusion overnight allows us to undertake transplants at daytime, and this has been demonstrated even for co-perfusion by the DART group in Groningen. Okay, so let's see how each machine perfusion technology fits in. I think the question is, should it go with ex situ or NRP for the DCD? And if we use one, for example, in the DCD, is additional graft treatment required? The first comparison of NRP with HOPE was undertaken a while ago now with highly selective group, and again showed with propensity matching no difference in outcome, but they highlighted the limited functional assessment during HOPE. NRP has demonstrated clear benefit versus NMP as published by the Cambridge group. Here you can see that NRP in red has the lowest incidence of ischemic cholangiopathy versus ex situ and NMP, but this is NMP undertaken at the recipient hospital. I think there is a need for data when NMP goes out for the donor and the liver is placed on the machine straight away. But if we need additional machine perfusion, which one we would use? So this was a study undertaken in Europe where a lot of machine perfusion is used following NRP. This appears to be primarily hypothermic and in the DHOPE facility, so perfusing both artery and vein. Now, the question is, why spending more money? Why undertaking both those perfusion technologies? And this is an interesting study because it compares NRP alone with NRP plus HOPE. And you can see clearly here a number of differences. First of all, longer functional warm ischemic time was NRP with HOPE. And this is from Italy. And of course, it shows no difference in outcome. So my interpretation here is that you may need additional perfusion strategy, be it HOPE or NMP, in the context of extended functional or ischemic time donors. But really, is that true? And I think the jury is still out there, because some of the data from the UK, as shown on this slide, with NRP alone, with quite extended functional or ischemic time of over 60 minutes, showed no difference in survival. So I think we need more studies to understand the benefit of combined perfusion technologies. And I think it's also important to highlight that CDCD, as I've shown you earlier on, with NRP alone brings results comparable to DBD. But let's say we do need an additional perfusion technology, and the question is which one? And I think this is an interesting study published about 6 months to a year ago, where NRP was compared with NRP plus HOPE or NRP plus normothermia. But it's interesting that hypothermic machine perfusion was used primarily in type 3 DCD, whilst normothermia was used in uncontrolled DCD donation. Perhaps not surprisingly, there was no difference in any of the parameters analyzed in the study. But the important bit was in uncontrolled DCD donation, there was 20% graft failure 3 months. This is staggering. And when you consider that you used NRP plus NMP, so both normothermic with a lot of ex situ and in situ assessments, we still have not identified the grafts that will fail. So yet more work to do here also. So how do we make sense of all this? So in the DCD, perhaps one of the options, we start with NRP alone here. As we increase the risk factors, be it age, be it functional or ischemic time, be it the no-flow period, perhaps we need to add other technologies, be it hypothermic, or if we need additional assessment, normothermic ex situ perfusion. And this is kind of the strategy that's developing in Europe. Another approach is to combine those, and this is for the DCD and DBD as well, where you start with HOPE, you have a period of controlled rewarming, and then you have a functional assessment for about 2.5 hours during NMP. And with this strategy, we seem to have a much gentler manipulation of the organs with excellent graft outcome. But this is quite labor intensive, and it's quite tricky to undertake. And I think we need better technologies here to see whether this approach works. So how do we summarize all this? Well, we have the donor liver, we do the procurement in DCD or DBD, then we can use HOPE, treat, accept, evaluate, and then discard or transplant. And if it's not sufficient information with HOPE, perhaps we need to go to longer-term NMP to further evaluate the organs, and then repeat viability testing, and then finally make a decision. So this strategy really is complex, but really pushes the boat out to allow us to maximize utilization of every organ, because really, in my opinion, no organ should be discarded without a proper functional assessment using perfusion technologies. And as a result of that, because we know clear which one works, in Europe, we will be undertaking this comparative study. This is in DBDs, extended DBD criteria, comparing the use of HOPE versus NMP. This study has started recruiting. Okay, so we have technology. How do we make them work in practice? And I think it's complex. I think a perfusion service requires staffing, education and training, infrastructure and funding, but needs to be supported at institutional level and have an adequate change management. Recruitment and education are key, and we can nowadays design a teaching program around machine perfusion, looking at basic theoretical and practical component, then looking at experiential training, and ultimately producing competent and new practitioners of organ perfusion practitioners. It comes at a cost, and I will skip quickly through this, because essentially what it shows that the cost of NRP per patient is about £4,000. The UK government willingness to pay per QALY is for intervention is under £60,000. And as you can see here, that the QALY either on a 10-year or a 100-year horizon with NRP is significantly lower. So this really is no-brainer in terms of utilization. And this is demonstrated further on a liver-only model, where you can see very clearly that you have a significant saving in terms of per patient surviving in terms of £33,000. That's about $40,000 per case. In the US, things are different because the ex situ machine perfusion provide a service for all the centers where the liver is delivered on a machine. And you can see clearly that the ex situ NMP is on average $80,000 per liver, whilst NRP is about $2,500 per organ recover. So really, it's a question of what your institution can afford and where you should draw the barrier. But clearly, for DCD, perhaps we should not jump to the most expensive toy straight away. But the real world is different. And I think it's important to understand that machine perfusion in high volume centers is used for what it's supposed to do, whilst in the low volume center, the choice is driven by the funding and the feasibility. In other words, how simply it is to use. So we see that centers embark on machine perfusion, but for totally different reasons, something that is affordable and improves a little bit their outcomes. But one of the benefits for machine perfusion is the tantalizing concept of organ repair center. So instead of taking an organ from the donor to the transplant, we take it to a center where it's repaired, and then with a clean bill of health is sent to the transplant center. So that takes me for the next sort of 10 minutes or so for the future. Where are we going with technology? Where are we going towards extended preservation? And we already perfuse livers up to about a week. Livers have been transplanted after 3-day perfusion. So clearly we're seeing this is where we're going. But the advantage of machine perfusion, extended one, is that allows us also to intervene, to start repairing the organs. So we're moving towards precision perfusion, viability testing, organ modulation, and also alter immunogenicity of the transplanted organs. A number of strategies are considered, repairing the IRI damage, changing the blood group composition as has been done in the kidney, trigger regenerative therapies, and undertake various cellular or gene therapies. The first simple step, because many organs livers are discarded because of fat, is defattening those livers. So after some of the initial study, now there's a UK clinical trial looking at defattening the liver and transplanting those and see what the outcomes are. But I think the more important one is the cellular senescence and liver preservation. And some of the work we did in Edinburgh was looking at biliary senescence, and we demonstrated that there's two different approaches. There's senescence in the cholangiocyte and apoptosis in the hepatocytes. And we demonstrated that elegantly here with that the longer the preservation time is, the more the damage in the biliary tree. But this also allows us to intervene. So we started giving senolytics either at the time of procurement or during machine perfusion, and we have seen a significant repair of the biliary tree. And you can see here that antisenolytics deliver machine perfusion increases the repair of the bile duct. This also opens the way to bioengineering, and I won't go into the details of all this, but there are a number of sources, either hepatocytes, mesenchymal stem cells, or embryonic cells. Things are going quite well, and a lot of development work undergoing here. One of the works we did was to use human biliary epithelial cells that were taken from discarded human organs. These were grown and isolated in a GMP facility, characterized and then transplanted here. As you can see, they engraft in the area of damage, repairing the bile duct. An alternative approach is to use cholangiocytes, and this is something that was promoted by the group in Cambridge, where cholangiocytes were isolated from the bile duct and the gallbladder, characterized and organoids derived. And once those were created, they were injected during machine perfusion in the biliary tree, and they have demonstrated they engraft and also start producing bile. So there's a number of strategies that we're looking at now trying to repair those organs. But there's a novel use for machine perfusion with xenogeneic cross circulation, where organs can be used to support function of a damaged liver. And you would be aware that the first decedent model, such an approach was used in Philadelphia recently. And of course, we can use perfusion, take organs, bioscaffolding. Long-term perfusion allows us to do that and to move forward. But also, and I think this is quite interesting, is allowing us to perfuse diseased organs, so organs that are removed either with cancer, with hepatitis, and allowing us to test different therapies targeted to the organ of choice, and it's something that we really need to look nowadays, and as a fantastic model for research and testing oncological therapies without the risk of side effects. There are a number of issues to address before we can look at therapeutic interventions. First of all is duration of perfusion. This has now been undertaken successfully by the group in Sydney, where they split the livers, perfused them for a week, and demonstrated that they can undertake successfully preservation for a long time. We also need to consider the implication of the liver-gut axis and the circadian variation. And I think there's a lot of work to be done here because we do not understand fully the interaction between the liver and the gut and how this impacts the perfusion long term. And of course, we need to move with technology because devices need to be automated. We can't afford to have someone stuck to a machine for about a week to 2 weeks whilst we're undertaking all these approaches. But there's a lot of work going on at the moment to ensure that. And of course, for any intervention, there is a route of administration, and the liver is a phenomenal organ. Could you do it through the bile duct, as I've shown you earlier on? Should we intervene through the artery or inject through the portal vein? And this is some of the experimental work we did, where we testing various routes of perfusion to find the optimal one for stem cell therapy. And finally, it's the assessment of intervention. Now we're looking at different things. We move away from the cholangiocyte, the hepatocyte function, to understand exactly how specific therapies are delivering. And I think we need to devise appropriate measurements for intervention assessment in terms of senolytics, RNA defattening, and so on. So I will summarize by saying that now machine perfusion is really establishing clinical practice with excellent clinical results and demonstrated increased organ utilization. We have a number of challenges, but also opportunities to make things better in terms of longer perfusion, what type of perfusate, which organs we need to perfuse, and what the combination of the technology should be. How do we deliver this? Is it in a single center or is it in a purpose-built facility, and so on? But also, and I think this is really the important view for the future, is actually machine perfusion has become now a step towards precision perfusion and organ repair. It creates a platform for testing of various therapies, allows us assessment in real time, and we need to consider how we deliver and what is the optimal technology. I think we have a number of preclinical and clinical testing of therapies coming up. It allows a perfect integration with regenerative medicine. And so far, a number of therapies are considered for clinical trials. So I'll stop here and say thank you very much and look forward to our discussion.